All right, let's talk a little bit about what has become almost as bad a situation as the neurosurgery situation that was offered up, maybe in some cases a worse situation, which is the placement of psych patients. Here in Los Angeles, it is, and I know everyone here isn't from LA, but here in Los Angeles, the number of inpatient psych beds available for the psychiatric ill is astonishingly small, and the resources available are almost non-existent. It is somewhat of a high-stakes game, but low risk overall. Obviously, if you're the last person to have handled the hot potato and they then complete a suicide, if they have someone who loves them, they're going to ask why you didn't hospitalize them. And so part of the job here is to not be the last potato, the last one with the hot potato. The other question that comes up with this is, for how many of you use something like a PET team, a POW team? You pick the words, you know, psych on wheels, psych eval team, psych emergency team, where they come and assess the person for their holdability, whether they should be placed and, you know, lose their personal freedoms and be involuntarily hospitalized. One of the things about that is sometimes there's a disagreement of opinion. You really think the person needs to be held, and this person who's not even a doc, right? They're often a psychiatric social worker or a psych person, comes and says, no, they don't meet the criterion to be held. Did they have any magic basis for that conclusion is one of the things that we can look at. And in fact, even if the psychiatrist comes and assesses their suicide risk, are they any better at it than us is one of the things we're going to look at, because it's an important thing to know. If they're really better, then fine, we can defer to their judgment. If they're not that much better, then maybe we ought to be a little cautious about it. Why has this become a big problem? Across the country, psych beds, inpatients have closed. Inpatient psych facilities have closed. Long-term psych insurance, very difficult to get. The rules to get a managed healthcare organization to pay for your psych hospitalization, almost impossible. I'll have to tell a story. It's a true story. It's almost unbelievable. But when they closed all these facilities in Los Angeles and all of these suicidal and psychotic people were put back on the streets and out in board and cares and things, I knew some of the psychiatrists who were caring for them. They're like, these people need to be hospitalized. I can't keep seeing them. Like, this one patient kept going to the psychiatrist I know and saying, I'm very, very suicidal. He wasn't responding to his antidepressants. Every time he showed up, which was, you know, twice a month, he would say, I'm going to blow my brains out. And the psychiatrist would ask, do you have a gun? He said, no. Where are you going to do it? He goes, I don't know. He goes, how are you going to do this? The guy says, I don't know, but there's lots of guns around. And so the psychiatrist, right, remained suicidal, ill-formed plan, you know, still recommend inpatient psych bed for him, no resources. And because the guy, as many psych patients do, didn't have a car, you know, he would go out to the psych transport van that would go to the board and cares to pick him up. So he goes out to the board and care, to the van driver to take him back to the board and care and says, take me to the shooting range in Pomona. And so the van driver says, I don't know if I can do that. So he goes in and sees the doc and says, Doc, the patient wants to go to Pomona. The doc says, take him where he needs to go. Leaving out, you can see how this miscommunication. So, sort of like in a Gary Larson cartoon, the psych van pulls up to the shooting range where they give the guy a Glock. He doesn't have a license or anything, but they give him a Glock with some, you know, psych ID. And the driver's out there, where is he? Sure, he's there for a long time, you know, waiting for him. And, you know, sure enough, the guy went and completed his suicide, being brought to the shooting range by the psych transport van. Anyway, no resources is what I'm talking about. And so the first two papers I love are papers that ask the question, are you as docs willing to deceive the managed care organization to get someone care that they need? Oh yes. Not all of you, but many of you, and I certainly am, because we know in Los Angeles what the managed care organizations, they have their names and we have what they really mean. HealthNet, HealthNut. Aetna stands for All Emergency Treatments Not Authorized. Cigna stands for Call and Get No Ambulance. You know, you can go down the line. We know what they mean. They're not going to happen and they're hard to do. And so Abstract 1 asked emergency physicians, 450 of them, they gave them 6 vignettes, chest pain, etc. But one of the vignettes was psych. And they said, how often would you lie to the managed care organization to get that person care? They said, oh, no problem, a third of the time. Whatever I needed to do to get them care, I would. And so the number of resources have become so scant that we will lie to get them placed, is what it says. We will actively deceive those on the other end. Abstract 2 says, and the reason we would do this is because the managed care organization criteria for hospitalization, even if the person has psych insurance, are so unrealistic that I have to lie to get them in. So this paper was interesting. They looked at the managed care requirements to be hospitalized for psych and compared them to a real 100 people on an involuntary hold who had been hospitalized. And what they said is the managed care organization said that if you had an absence of a plan, you're really not serious. They said that if you had an absence of a prior attempt, you got to really show us that you mean it before we're really going to consider hospitalizing you. And the managed care organization said that if they didn't clearly say, I want to kill myself, you know what this is like. A lot of people sound like they want to kill themselves, but they're like, no, I just had a headache. I took 750 Tylenol. It wouldn't go away. Were you trying to kill yourself? No, it was a bad headache. Yeah, right. Please. And then they compared, so that's what it took to get the managed care organization to do it. And in real life, they had 100 adults on hold. 69%, no clearly stated suicidal intention. 84%, no plan. 67%, no prior attempt. What this paper shows is that the managed care organization's requirements to be hospitalized are completely out of step with the reality of who needs hospitalized. And that's why we have to deceive them. The largest psychiatric facility, this is astonishing, in the United States, the LA County Central Jail. That's how good our psych resources are. We have criminalized psychiatric illness in the United States and are doing so. Then there's the next set of lies that you might entertain when you're dealing with a psych patient is you got someone who comes in who's clearly crazy. They're young, they're healthy, they seem to have no comorbidities. In fact, they often will tell you, Doc, nothing wrong with me, I'm just crazy. I'm hearing voices, I know I shouldn't be hearing voices, they're persistent, I'm nuts, I've been going nuts for a while, get me some help. You say, you got diabetes? No. You got, no. In fact, many of them are fit. They look great. And so you call the psych team and they say, well, wait a minute. I mean, we need to medically clear him first. I need a chest x-ray, a CBC, Chem7, and you're like, the guy looks like he could run a marathon. They're like, no, we got to have it. And so we balk at this Psych Clearance stuff, and there's three papers here, 3, 4, and 5 on it. Abstract 3 is by Carrie Korn. When I was the residency director at LA County, she was my program coordinator. And we said to our psych people, hey, listen, the person's house says they're healthy, but they're crazy. They said, yeah, but they're crazy. How do you know they're healthy? We say, they look healthy. They say they're healthy. There's nothing wrong with them. They're young. They say they're crazy. We want to send them straight to you. They say, we said there's literature that says that there's nothing wrong with these people. They can go to you. And they said, yeah, we know there's literature. But none of that literature dealt with an indigent, inner city, drug abusing, HIV positive patient population like here in LA County. We went, you're right, none of the literature does. All right, we'll test it. That's paper 3. So we took our indigent, inner city, multiple illness, kind of TB, et cetera, patient population, and we did everything they wanted us to do. H&P, vital signs, a basic metabolic panel, a CBC, tox, serum, and urine, chest x-ray, and a beta HCG on everyone, screening to see what the yield of it was. And when the patient said they were sick, of course, the tests were frequently positive. They said they had diabetes, their sugar was high. But when they said there was nothing wrong with them, and they said, doctor, I'm just crazy, there's nothing wrong with me, how often were the tests wrong? Well, they were never helpful. There was one elevated white count, I believe it was 20.7. No cause was known for it. Basically, I think the guy degranulated because he was pissed off because we wanted to do all the tests. You've seen people who can degranulate from being angry. He degranulated. He never spiked a temp. We rechecked it 6 hours later after he got his Ativan. It was 7, and it never went up again, and he never had any problem. And the other thing we found was a woman who was pregnant. That was it. That was the full yield of that battery of testing done routinely, even in an inner city population. However, on the flip side, if the patient is trying to tell you they have medical problems, a lot of times we force patients, right? You know this feeling, right? It's not a shopping store. You can't have one from column A and one from column B. Tell me what the problem is today, right? And so they say, I have a broken ankle. And you go, I love that problem. Let's start with dealing with your broken ankle. We'll do an exam. We'll do the auto ankle rules. You maybe need an x-ray or not. And then the person says, I got a broken ankle because I jumped off a bridge because I was hearing the devil. And you're like, don't tell me about that. You are here for your ankle. So we both ignore the psychiatric problem in favor of dealing with something nice and concrete sometimes. And sometimes a patient comes in and says, I'm crazy. And you say, is there anything wrong with you? No. And you say, well, what meds are you on? Oh, I'm on HIV meds. I'm on this. I'm on that. Like, but you're here because you're crazy. So you want to pretend that there's not this other building history of their medical problems, and you want to corner them and send them off. And even the psychiatrists, by the way, are aware of this. I'm not bashing my psychiatric colleagues when I say this. Even your psychiatric colleagues, if you talk to them carefully, will tell you, if you're sending someone to a locked facility and you're in the ER, remember, you're the last doctor to see them. We're psychiatrists. We went to medical school, but we can't handle even hypertension. We certainly can't handle alcohol withdrawal. You know, none of that. So all of those things are going to be beyond our facility. Abstract 4 by Olshaker, 345 patients. They noted that almost 20% of all ER visits have a psych complaint, and disproportionately on weekends and holidays. And they asked, what's the yield of the workup? And they said 19% of the patients had medical problems that were coexisted. So if those medical problems are there, you got to look at them, because that might be contributing. But the sensitivity of labs overall in the ones who said they didn't have a problem was 20%. Very, very, very low sensitivity. Only 4 patients in that 345 had a problem not anticipated by their H&P. In other words, you got a kind of psych patient who's there and says, you know, starts telling you what's wrong with them and what's not. Their H&P is pretty believable. The bad psych patients, the ones who aren't believable, you think they came to the emergency room? No, the ones who came to the emergency rooms are the ones that have some modicum of insight. And 5 is a cautionary counter paper that says, hey, listen, medical disease is present in psych patients up to 80% of the time. From 20% to 80%, that's a lot. And it says, so you got to be really cautious. If the patient has any new medical symptoms at all and you don't react to them, you're asking for trouble. So it says you can't plug your ears and pretend not to hear their medical components of their complaint. If they got medical components, run with it, be generous with your testing. If they have no medical components, fine, then you could do selective testing only. And then they add, if they're over 60, please get an EKG and a chest x-ray to make sure there's not something ugly there. So I can live with over 60. I can live with that number. I mean, I might like it to be a little higher, but that's fine. The next group of papers deal with predicting risk. And the most known way to predict risk is the SAD persons, that database. The mnemonic is SAD persons, where S stands for sex. Men will kill themselves far more often than women. Women try a lot more. They just don't succeed because they take pills, which just don't work. Age, if you're a teenager or you're an older man, you're going to kill yourself. Those are the ages. Depression, if you carry a known DSM-4 diagnosis of depression, you're at greater risk. If you say you have depression, you're at greater risk. If you have a prior attempt, you're at greater risk. If you have alcohol abuse, particularly at the time you're seeing, your risk is 50-fold greater. Alcohol is a major, we could talk about alcohol. Alcohol is a major promoter of trauma, to be sure, but it's an even better promoter of suicide. If you have rational thought loss, that's the R in persons, rational thought loss, i.e. you're getting psychotic because of your depression, you're at greater risk. If you have social supports which are weak, which is everyone left you, you're at greater risk, but particularly for men. Older men without a wife are at much, much greater risk. Women without a husband don't seem to be at that much risk. You know this t-shirt, you've all seen it. Women need a man like a fish needs a bicycle. It does not appear, however, to be the other way. Men apparently do need women where it comes to suicide risk. Organization of a plan, presence of a gun increases your risk. If you have no spouse, you're at increased risk. And finally, if you have a sickness, the S in SAD persons, particularly if the sickness is cancer and you're a man, you're going to kill yourself. So 6, 7, 8, and 6 through 10 all deal with this. And they all answer this question, directly some, indirectly others, that neither the psychiatrist nor the psych social worker or the person who comes to evaluate your patient has any crystal ball. They are no better than you at assessing risk, that it's all a crapshoot. Fortunately, the odds are in your favor. The overall risk for suicide is about 0.2% of the people who you see are going to go ahead and complete it, but about 5% are going to try one way or another. So 1 in 20. Those are numbers from Abstract 10, which is a 2006 New Mexico 10-year data set. Abstract 9 is a paper I love. This is a hysterical paper. It's worth getting the original manuscript. It talks about occult suicidality in the ED population. By definition, if it's occult, no one knows about it. How did they find it in this paper? Well, they went out into the waiting room and they surveyed the non-psychiatric patients, the non-psych chief complaint patients in your waiting room. They're waiting to see you. They're there with an ankle, they got this, they got chest pain. They asked them, what they found out when they surveyed the people in the waiting room, 11% were passively considering suicide. That's just because they'd been there for, in my yard, 12 hours waiting to be seen. 8% were actively considering suicide, wondering where they were going to get the meds or the weapon to do it. 2% were actually in the planning phase. They were going to steal somebody's meds or their weapon to do it. Of the 31 patients those percentages all added up to 31 total. Of the 31 patients who were in some form or way considering suicide, only 12 were recognized by the emergency physician when they were seen as having a psych emergency present. So only, a little bit more than a third. Love that paper. In terms of quotes from the literature that will support you, if you were the last person to hold the hot potato and then the person went out and killed themselves, I like 7, which states, quote, "The emergency physician cannot be reasonably expected to be completely accurate." And then another quote, "Currently not possible to predict risk. There are no good risk prediction tools out there." And finally, "No study has ID'd a successful risk prediction tool," end quote. So that's the kind of paper that says this is a really hard thing to do, and you're not, and particularly with the lack of inpatient resources available to you, it's quite hard to do. Now, when are you at the highest risk for getting sued? You see some psychotic, homeless guy who's been to your ER 7 times, who comes into your, and this is our situation at LA County, who comes in and you sort of patch him up, make some outpatient mental health resources for him, and do your best, and give him some Librium for his withdrawal, and send him on his way. That's pretty standard county hospital care. The guy goes out and kills himself. Are you going to get sued for that one? No, his family doesn't even know where he is, let alone love him. They wish he killed himself 10 years ago. So no one's going to sue you. There is one situation where you are very, very high risk. A mother brings her 15-year-old kid into the emergency room and says, "Dear God, please help me. My kid's out of control. I'm worried about them. They can't do it." And you kind of see them and try and bring gravity to the situation. You have the psych eval team come, and they go, "Oh, this kid's not holdable. He's got resources. We'll send him home with mom. We'll set him up for outpatient psych." Mom is like, "Please hospitalize my child." You get that one wrong, if you're the last one to hold that hot potato, you're going to get skewered in court. You're going to go down. Because that mother is frustrated with the system, is trying to get help for her kid, knows there's a problem. Abstract 11 looks at adolescents. Remember, it's a bathtub curve. Adolescents are a high-risk group, then the risk goes down through the 20s and 30s and 40s and starts going up again at 50. So that's kind of your curve for suicide. This paper 11, very informative, says when you made these arrangements for these people, 16% of the adolescents never saw their outpatient psych follow-up that was arranged in the emergency department. 16%. 35% did follow up with their outpatient psych, but went 2 times. Oh, that cured them. Sure, 2 visits straightened them right out. So if you say that's not following up, which I would say, now you had 35 and 16, you're up to more than half of these kids never followed through with any of their psych follow-ups that were arranged for them in the ER. These are very high risk. So lots of bad numbers, and the parents can't control these kids. If that kid completes their suicide and you just chose to manage them on an outpatient basis despite their pleading with you to hospitalize their kid, you're going to eat that one. Abstract 12 is a Harvard PZR brief screening tool. People are in search of the holy grail here. There's lots of these papers, we already did the SAD persons, there's various screening tools. They said they had a screening tool with a sensitivity of 98%. I put it in there more for humor's sake. I don't think it's true. Most of the literature suggests that no screening tools are that effective. But there's one thing that was interesting. When they looked at people in Abstract 13, both kids and adults, so the kid tries to commit suicide, they come into the emergency room, everything's okay, you've saved them, and there's 3 things that a person who tries to commit suicide could feel when they're not dead. They could say, "Oh shucks, I wish I was dead." That's a very bad thing for them to say. That means they're at much greater risk. They could say, "Oh great, I'm alive, I really didn't mean it, it was such bad impulse control." That means you might be able to get a wedge in and they might get better. Or they could just be flat affected and go, "Yeah, so what, I'm alive, I could be dead, who cares, one way or the other." That's also not very good. But if they say, "Oh shit, I'm alive," that's bad. Do not let them go. I included abstracts 14 and 15 in this paper because the literature on the topic, this is a small piece of it, is very, very clear. That you need to be able to go from domestic violence to suicide and from suicide to domestic violence. These two go hand in hand for women. Many of the times they overdose, so they're not completed suicides, but any woman you see with an overdose or a suicide presentation, you need to get some quiet time with her and find out whether she's getting smacked around as part of what her dysfunctional relationships are. And then vice versa, if you see a woman who you think's been smacked around, you better find out the other way, whether they're suicidal because of it. And so those two are partners in crime, if you will, or partners in pathology. So both DV and suicide go hand in hand, and you ought to be bi-directional. 16, hysterical paper. I mean, not hysterical in terms of the topic or the outcome that they prove, but very, very funny. It asks the question, you got a suicidal woman. We know that women basically take pills. They don't succeed very often. This one asks the question, if she showed up at a gun shop and purchased a handgun, what does that mean? Well, it could mean two things. It could mean her depression's getting better and she's thinking of learning how to quail hunt. Could mean that. But this paper says no, that the risk of her committing suicide, if she made a gun purchase recently, it probably isn't for quail hunting. It's probably to blow her brains out. The risk of a completed suicide, 39-fold greater in a woman who recently buys a handgun. So if you're seeing a woman who's depressed in an emergency room, maybe she took pills or was drunk at the time you saw her, or maybe it was a DV complaint. If there's a handgun available or if she recently purchased a handgun, she's going to do it. Do not let her go, is what that paper says. And 17, funny paper as well. 17 gets it all wrong. 17 asks the question, is lunacy real? Does the full moon cause behavioral changes? And they went ahead and they measured the gravity and they looked at all these things. They said, the gravitational pull just isn't great enough on any, because humans are small and the moon's far away. The moon's able to pull on the planet, but not really on any one person. The mass of the person is just, the relative masses, it just won't work. And that obviously lunacy, therefore, is false. And the paper goes on to say that the multiple papers have asked the question, does census go up during the full moon in any meaningful way? No, it doesn't. So obviously, lunacy is false. Not so fast. Lunacy is real because people think lunacy is real. That's one thing. Secondly, if you ask the poison control centers if their volume goes up, oh yeah, big spikes around the full moon at the poison control centers. Now, so let me ask you a question. Which shift seems longer? You, ma'am, worked a 12-hour shift where you saw a cardiac arrest, a few septic old people from the nursing home, a couple of ankles, and a wrist. You, ma'am, worked a 12-hour shift where you saw a cardiac arrest, a couple of ankles, and 5 overdoses, barfing charcoal all over. In the end, you both saw 14 patients. Your shift was 12 hours long and felt 12 hours long. Your shift was 12 hours long and felt a week long. So even if the census didn't change, what was happening in the emergency department did change because of the overdose volume. And then the second thing that this paper missed, which is really important, is if I was to ask any person in the room here, what's your primary sensory organ? The retina, the eye. And there is one thing that's unavoidable that a full moon does, which is it prolongs the period of light outdoors, so activity can go on. Part of the reason you go to bed at night is because you can't see anything. And if there's a full moon, you can, and so your activity level goes up. And so this paper says that the gravity doesn't do it, but it missed the fact that there's another feature of a full moon, which is called light, and I'm a lot more sensitive to light than I am to gravity. And then finally, the poison control data does suggest that while census overall doesn't go up, the types of patients you're seeing might change on the full moon to make them a little more evil shifts. 18, last paper in this segment, is a fun paper that says a couple of things. It says if you're seeing people, and you kind of know them, that have some underlying psych issues, be careful what you prescribe them. So, for example, if you're seeing a low back pain troll who's on their 13th visit in the last 6 months, who seems to maybe have some drug dependency issues, or certainly is consuming a fair amount of narcotics, and this person seems a little depressed, and when you see them and they're not very happy, and by the way, if I had 13 visits and had chronic low back pain, I might be depressed. That's a chronic painful condition where depression might be. This might not be the time to write them for 90 Flexeril. And we've seen that, by the way, in our hospital several times. The orthopods like the Flexeril, and I don't know how many of you have ever heard Mike Heller give his talk about low back pain, that you should give the patient, Mike Heller says, so when you see someone with low back pain, after you verify that there are no red flags and they don't have any neurologic problem and it's not a AAA and all that stuff, he says that you should prescribe them the combination of Vicodin, Motrin, and Flexeril. And that you should tell them that the Motrin should be taken every 8 hours, but only after a meal. And that the Vicodin should be taken every 6 hours, 1 to 2 tablets. Please don't increase it to 3. And that the Flexeril should be taken every 7 hours, but preferably before meals. And he says that by the time the patient actually figures, he says you should use prime numbers. Confuse the patient. Give them a regimen that if they actually thought about it, they would be so confused trying to figure out when their medications are that by the time they figured it out, their back pain would be gone. And that particularly the role of Flexeril in this is to addle the patient. We know that Flexeril doesn't really do much, but it does make people feel confused and dingy. And that the real purpose of Flexeril is to confuse the patient with low back pain. I have now seen several, and the orthopods at our facility, I'm quite convinced, use Flexeril with exactly that in mind. The problem is that some of them are depressed, and Flexeril is a tricyclic antidepressant. If you take 50 Flexeril, it's just like a TCA overdose. So this paper points out, they looked at 30 patients, 5 hospitals, they had a lot of different names, a lot of different visits, and that 2 of the 30 died on stuff that was prescribed for them in the ER. So be careful if you're sensing a little depression thing, don't arm them with a lethal quantity of drugs on the way out the door from seeing you. When you were saying, I don't want to hear about your psych problem because there's no resources, and you were saying, here's your Vicodin, let me give you 50 Vicodin for your ankle sprain. Probably not a good idea. And by the way, I'll tell you, I've also done some expert witnessing on cases about this. There's one, opiate overdoses in the emergency room, pretty straightforward, right? They come in, they got pinpoint pupils, they're not breathing very much, they're breathing very shallow. You give them some Narcan, they wake up, they turn into an asshole more or less, and they want to leave. That's pretty much standard care. And every once in a while, I catch a resident about to let one of them leave. If they're heroin overdose and they wake up and you watch them for a little while and they're not desatting and they don't get heroin-induced pulmonary edema, I got no problem with them leaving. What the interval of OBS is some measure of debate. In Vancouver, they tried to make it 1 to 2 hours, which was a little short. A couple of them bounced back. I think at 4 hours, you're there. They won't bounce back. And they're not going to resedate. The Narcan's long gone after an hour. The Narcan's gone. But the problem is the person wakes up and the resident says, and you go to look and you go, tracks? And the resident says, well, they're not an IV drug abuser. Oh? And how did they get all this opiate in their system? Well, they took Vicodin. Oh? So if you take enough Vicodin to be an opiate overdose, you need Mucomist. So it's one thing to reverse their narcotic OD and let them go if all they got is a narcotic. It's another thing not to recognize that a lethal overdose from the Tylenol component of their, if they're on, and it's not just Vicodin, it's oxycodone and the other ones, Kentucky heroin. So be careful if you're seeing your opiate doses, that's another one where they come in with the, with what looks like a straightforward opiate overdose and you fail to check a Tylenol level or consider the Tylenol component. And that's where the ER docs get burned. Vicodin is the drug that's burning us more than anything. I mentioned Flexeril as well, but there are some other things out there. Benzos can do it, right? A nice little combination, a little cocktail of benzos and alcohol will take people down and allow them to complete a suicide if you prescribe them. So this paper 18 says, be careful, watch the meds you write for. It's a very small survey of 30 patients where 2 of them died. And by the way, if you look at that paper, there's some other entertaining things about them. Those 30 patients, they ranged from 1 to 6 names in the medical systems at the hospitals that they've been seen for. The average number of names they had was 2.2. They averaged around 12 visits a year, and they averaged 88 inpatient days a year. These are not, you were mentioning that some of the patients are harder than others. These are the hard patients. By the way, they don't come in on Tuesday when Bob's working from 10 to 4. They come in on the weekend. All right, I'll end it there. That's some stuff on suicide. It's a troubling area to work in because there's so few resources, and the resources, just as you were asking about neurosurgery, are getting less and less and less. Any questions, comments?
My favorite thing is the alcohol increases the risk of suicidality, and the ability of getting somebody who's been drinking evaluated close to 0.
Right, so many of these PET teams and stuff say we won't come see the patient till their alcohol level is 100 or less, which is like a nightmare. The guy's alcohol level is 500 right now, and so you're thinking, well, 30 per hour. Before you draw, the range of alcohol metabolism is 22 to 30 per hour, and the kinetics are very fixed. You might, the concept that the drinker is a metabolizer, that's false. The drinker is a tolerator. You don't induce metabolism of alcohol. You induce tolerance. And so the level's going to drop between 22 and 30 per hour, regardless of who they are. 22 per hour if they're Asian, 30 per hour, some variants if they're a larger person. But 22 to 30 per hour is the rate at which it's going to drop, period. You don't induce metabolism. Right, yeah, no, we have patients who, if we get them down to 100, they're withdrawing, and now they're not clear.